Welcome back, colleagues. If you are preparing for your postgraduate exam or practicing on the labor world, take this note. The Royal College has officially overhauled its guideline on reduced fetal movement. The old rules are gone. Today, we are breaking down the exact clinical pathway you need to master for your exams and your patients. So, let's go. First of all, we will discuss the definition and the maternal perception. The definition is the maternal perception of a significant decrease or total cessation of fetal activity. The onset perceived between 18 to 20-week gestation, the pattern plateau in 32-week gestation, and no normal reduction in the third trimester. At the crucial 2026 update, there is insufficient evidence to recommend formal fetal movement counting using specified numbers, count to 10, trust maternal perception of a change in pattern, and the key fact for the new guideline is 32-week gestation movement pattern plateaus does not decrease near term. So what is the etiology and associated risks? Reduced fetal movement is a warning beacon for placental insufficiency or congenital anomalies or fetal growth restriction or small for gestational age. The clinical consequence, impending fetal compromise or intrauterine death when placental perfusion drops. The fetus conserves energy by reducing non-essential physical movement. So the clinical assessment workflow by gestation. Step 1, auscultate fetal heart with handheld Doppler to immediately exclude fetal death. Step 2, assess maternal risk factors, blood pressure, urine analysis, and measure symphysiofundal height. The management pathway depends on the gestational age. If less than 24 weeks, so confirm fetal heartbeat via handheld Doppler. If between 24 to 28 weeks, confirm fetal heartbeat and detailed history for stillbirth or early onset fetal growth restriction risk factors. If more than or equal 26 weeks, so arrange a computerized CTG to rule out acute fetal distress. What is advanced investigation and when to go for advanced and when to scan? Computerized CTG of more than or less or equal to 26 weeks used to exclude acute fetal compromise. First line investigation from more than or equal 26-week gestation. Provide objective assessment of fetal well-being. Detect acute fetal compromise rapidly, and normal CTG doesn't exclude all underlying pathology. The ultrasound scan more than 28-week gestation indicated if perception of reduced fetal movement persists despite of normal CTG, additional risk factor for fetal growth restriction or stillbirth are present, no scan performed within the preceding 2 weeks. The parameters to assess what will we assess is a triad: fetal growth, liquor, amniotic fluid volume, and umbilical artery Doppler. What is the single versus recurrent reduced fetal movement in clinical comparison with the new guideline? Both as two scenarios: single episode of reduced fetal movement and recurrent episode of reduced fetal movement. How will be the workflow in a single episode of reduced fetal movement? The standard pathway is the Doppler, CTG, symphysiofundal height scan if indicated, reassure if all tests are normal, and advise patient to return if movement decrease again. So we call like open door policy. If more than or equal 39-week birth could be offered. For the recurrent episode of reduced fetal movement, so full formal case review to aggressively exclude predisposing cause, assess for objective evidence of compromise. And if more than or equal 39-week gestation, birth should be actively offered, and we have to note the language. Single episode birth should be offered. Recurrent episode birth should be actively offered at more than or equal 39-week gestation. It's a common exam trap. High take-home message: high-yield girls for exams and the clinical practice. Never ignore any maternal perception of altered or reduced fetal movement. Must be taken seriously and assessed immediately. No hard numbers. Don't use kick chart anymore with fixed number. Cut off the focus on changes in the individual patient movement pattern. More than or equal to a 26-week rule, computerized CTG is a baseline tool to rule out acute fetal compromise from 26-week gestation onward. And the objective rule: do not expedite birth before 39 week unless there is a clear objective evidence of compromise for for gestational age, abnormal Doppler, or oligohydramnios. Thank you for continue watching our video. It was based on the last update of the Royal College guideline in April 2026. Hoping you find this useful, so subscribe and the channel.